Welcome to part 2 of fluid and electrolytes. We're going to focus on fluid imbalances. In a healthy body, fluid intake is balanced by fluid output. We lose every drop of fluid we take in. If we take in more fluid than we should, our body will regulate and excrete what we don't need. If we don't have enough fluid coming in, our body will regulate and hold on to fluid instead of excreting it. Unfortunately, not every body is 100% healthy all the time, and our body may have times where it can't regulate our fluid balance as well as it should. These times of fluid imbalance can be caused by alterations in the volume or distribution of fluids, or by the amount and concentration of the electrolytes. Sometimes it's because of both. When our extracellular fluid is low, we call this hypovolemia or fluid volume deficit. The loss of water and electrolytes is low in the same proportion. When the body has too much fluid, we call this fluid volume excess. If the excess fluid is in the intravascular compartments, we call this hypervolemia. If the fluid excess is in the interstitial spaces, we call this edema. As adults age, they become more susceptible to fluid imbalances, and sometimes we can't tell that they're having fluid imbalances until it's bad because the changes they have may be subtle. Someone who has fluid deficit may have delirium and be confused, and that might be our only symptom. The reason why older adults are more susceptible to fluid imbalances is because of their cardiac function and their kidney functions, and they decline as they get older. The heart doesn't pump as strongly and the kidneys don't filter out as well. Older adults also have decreased thirst sensations, so they tend to be dehydrated as they're normal. The first fluid balance we're going to discuss is fluid volume deficit. This is when the body does not have enough fluid. Specifically, the loss of extracellular fluid is greater than the intake of fluid. Fluid volume deficit involves the loss of both water and electrolytes in the same proportion as they would exist in the body if the body had adequate fluid. Because the fluid and electrolytes are lost in the same proportion, we call this hypovolemia. With hypovolemia, the osmotic and hydrostatic pressure changes force the interstitial fluid into the intravascular space to try to compensate for the loss of volume in the blood vessel. As the fluid in the interstitial space is used up, the fluids become hypertonic and cellular fluid is drawn into the interstitial space, causing the cells to not have enough fluid to function properly. So those cells are going to shrivel. If the body loses fluid only and not the electrolytes in the same proportion, then we have a different issue. We have dehydration. You may hear hypovolemia and dehydration used interchangeably, but they're not the same things, so using the terms interchangeably is not correct. There's one more cause of fluid volume deficits, and that's a phenomenon called third spacing. Third spacing occurs when fluid from the intravascular space moves to the transcellular compartments, like the pleural space, the peritoneal space, or excessively collects in the interstitial space. The fluid hasn't been lost from the body, but it's no longer in the vascular space, so the blood vessels have less fluid. Third spacing can occur for many reasons, but the most common are from changes in colloid pressure from decreased albumin or too much IV fluids. Third spacing is an odd concept because the body has not lost fluid. The patient may look very edematous, but their blood vessels do not have fluid in them, so they're really fluid volume deficit. I like to say that these patients are intravascularly dry. Their blood vessels do not have fluid. People can absolutely die from fluid volume excess, which would be really bad fluid volume deficit that causes the body to go into shock because the blood pressure goes so low and the body basically shuts down and dies. A lot of things can cause a person to have fluid volume deficit. First, we have abnormal losses of fluid. This can be from excessive vomiting or diarrhea, where the person is losing fluids from their GI tract. We can also cause someone to lose too much GI fluids by suctioning their stomach contents too much. This is a Block 3 topic you'll discuss a lot more then. Another way people can lose too much fluid is from excessive diuresis during exercise or extreme temperatures. Sometimes a person can have such a high fever that they're very diaphoretic and lose fluid that way. Another way a person can become fluid volume deficit is from decreased intake of fluid. This could be from nausea and other GI issues that prevent that person from taking in fluids. A person can also have decreased intake from lack of access to fluids. There could also be a combination of both of these types, especially in people who go hiking in extreme temperatures and run out of water. They lose excessive fluid from being diaphoretic while hiking in the heat, and then they run out of water, so they have decreased intake. We discussed third spacing of fluid from intravascular space into the tissues previously, but this concept happens a lot in critically ill patients, so you definitely will talk about this again in the later blocks. Another cause for fluid volume deficit are certain diseases like diabetes insipidus and adrenal insufficiency, which you'll learn about again in block 3. Hemorrhage will also cause massive fluid loss. One of the major problems about fluid volume deficit is it can develop rapidly depending on the cause. That rapid development can be life-threatening if it isn't reversed quickly. Think about those hikers in hot weather. It becomes an emergent situation to rescue these hikers. The severity of the fluid volume deficit is going to depend on how much fluid they lost. The more fluid that they lose, the sicker the patient will become. People with fluid volume deficit can have many symptoms and assessment findings, and the amount and severity of the assessment findings often relate to the severity of the fluid loss. The worse the fluid loss, the worse the symptoms and findings. With fluid volume deficit, we will see acute weight loss. Every kilogram they lose, or 2.2 pounds, is equal to 1 liter of fluid loss. The person's going to have decreased skin turgor, which we call tenting. The urine output would decrease to less than 400 mLs of urine a day, and the urine is going to start to look and smell concentrated. Their capillary refill time may be prolonged to greater than 3 seconds. Their blood pressure may decrease with an increase in heart rate at the same time because their heart is trying to compensate for the low blood pressure by causing a higher heart rate. The person may also become dizzy and weak. The person may be thirsty, but loss of thirst can also happen if they are very fluid volume deficit. If the person becomes confused, it may be due to the low blood pressure or changes in electrolytes. The skin may become pale and cool from the lack of blood pressure and perfusion to the skin, and the person may have flattened neck veins. If the fluid volume deficit gets too severe, the person will have decreased cardiac output, which is the amount of physical blood leaving the heart, and the person can go into shock and could possibly die. When we look at the lab findings of the person with fluid volume deficit, we're going to see a lot of changes. On our complete blood count, or CBC, we'll find an increase in hemoglobin and hematocrit level. This is because there's less fluid and more cells in the blood. The blood becomes concentrated. We will see an increase in serum osmolality because the blood is concentrated, and we'll see an increase in urine osmolality and specific gravity because the urine is concentrated. The urine sodium will be decreased because the kidneys are going to try to hold on to as much sodium as they can to keep that fluid in the body. When we look at a basic or complete metabolic count or panel, we will find an increased BUN and creatinine level. Normally, BUN and creatinine are in a 10-to-1 ratio with each other. 10 BUNs for 1 creatinine. With fluid volume deficit, the BUN will be elevated out of proportion to creatinine, greater than a 20-to-1 ratio because the urea in the blood gets concentrated. So how do we manage these patients? Well, managing a patient with fluid volume deficit is focused around replacing the fluid, ensuring the electrolytes stay balanced, and stopping and preventing the cause of the fluid loss. When replacing fluids, the oral route is always preferred. That's the way our body works, and it's the best way we absorb fluid. However, sometimes the person is so deficient in fluid that we have to give them IV fluid quickly to get them stabilized. Everything else we do is assessing our patient's symptoms and making sure they're improving. We do strict I's and O's at least every 8 hours as a minimum. We do daily weights, and we assess and monitor their vital signs closely. We can assess skin turgor, oral mucosa, mental status closely, and we also need to watch the patient's kidney function studies, that BUN and creatinine, as fluid volume deficit can cause kidney damage if the kidneys don't receive an adequate blood pressure and adequate amounts of blood. We also want to complete oral and skin care, as these get very dry and become prone to breakdown. We also need to prevent or minimize fluid loss, like treating vomiting and diarrhea as ordered. Fluid volume excess is the opposite problem. The person has way too much fluid in their body. They're overhydrated. This occurs from excess retention of water and sodium in equal proportions. This can occur from taking in excess water and sodium, or from a failure of our fluid balance mechanisms like kidney failure or heart failure. Excess sodium intake may also cause fluid volume excess. Think of a time where you ate a very salty meal and the next day your fingers and your toes felt fat and swollen. That's fluid volume excess. Normally our kidneys excrete the excess sodium and we pee a lot and everything goes back to normal. But in a person whose regulation mechanisms are not working the best, the fluid and the sodium don't get excreted. Due to the increased extracellular osmotic pressure from the excess water and sodium, the fluid gets pulled out of the cells to equalize the tonicity. By the time the intracellular and extracellular fluids equalize, the cells are almost depleted of their fluid and the extracellular compartments are full of fluid. All of that excess fluid in the extracellular compartments accumulates in the interstitial spaces, causing edema, or in the intravascular spaces, causing hypervolemia, too much fluid in the blood. People with fluid volume excess from edema in their dependent regions of their body, their feet, their ankles, their legs, their sacrum, and hands, the areas of the body where gravity pulls the blood down. If it gets really bad, the eyes and the sclera can get edematous. And if the fluid excess is really bad, it can start to third space and accumulate around organs like the lungs, the heart, and the abdomen. People can die from fluid excess, but what we see is the inability for the body to oxygenate, or the heart and kidneys completely fail and shut down. Heart failure and kidney failure to this severe extent are discussed in later blocks. We see many different assessment findings with fluid volume excess, and just like fluid volume deficit, the worse the fluid excess, the worse the symptoms. Someone in fluid volume excess will have acute weight gain, which could be pounds of weight overnight. Remember, every kilogram of weight gain is 1 liter of fluid retained in the body. These patients will get peripheral edema, which could turn into third spacing like ascites in the abdomen, pleural effusions in the lungs, and pericardial effusions around the heart. We can see distended jugular veins, and there may be a cough. We can hear crackles in the lungs, which sound like popping Rice Krispies, and the person may complain of shortness of breath. These two findings occur because fluid is filling the lung tissue, and instead of being like a dry sponge, the lungs are soaking wet sponges. And oxygen and CO2 do not diffuse through fluid very well, which means the person can also have oxygenation issues and an increased respiration rate. The blood pressure will be elevated and the person may have a strong bounding pulse. If the person's kidneys are functioning, the person will have increased urine output. But if there's any kidney dysfunction, they won't be able to pee out enough fluid to remove that excess fluid. When we evaluate a person for edema, we generally start at the feet and ankles, as this is the most dependent part of our bodies and the most likely location to find edema. Edema is classified as pitting or non-pitting. Usually we see pitting edema with fluid excess and non-pitting edema with injuries. Pitting edema is the type of edema where we can sink our fingers into the edema and it's going to leave an indentation. Or like a person who's wearing socks, that indentation may last a while if the pressure has been applied for a long time. The deeper the indentation with our finger, the more pitting edema present. A +1 pitting edema is about 2 millimeters indentation, and a +4 pitting edema is about 8 millimeters deep. There's a type of edema called brawny edema, which is where there's so much fluid that the edema turns hard. The skin turns shiny and warm, and it may be moist. Another type of edema is called anasarca, and this is severe, all over, weeping edema. If the person's eyes and sclera are edematous, they probably have anasarca. There are other types of edema that are not related to fluid excess, but I want you to take a picture or take a look at this person's eyes. This person has so much edema that their eyes are swollen. When we look at our lab values for someone with fluid volume excess, they're going to be the opposite of what we found in fluid volume deficit. In the CBC, we're going to find decreased hemoglobin and hematocrit because the blood is so full of fluid that it's diluted. We'll have decreased serum and urine osmolality, and we'll have decreased urine-specific gravity because the blood and the urine are diluted. The urine may be very pale yellow or even clear like water, and probably will have no smell to it at all. We will also see decreased urine sodium, not because the kidneys are trying to hold on to the sodium, but because the sodium loves fluid and will do anything it can to stay with the fluid, which means it's going to want to stay in the body. We will also see a decreased BUN level. We usually don't see creatinine changes unless the kidney issues are causing the body to retain the fluid. Although it's not listed as a common lab to check, we do check albumin levels to make sure they're normal. Low albumin levels will cause shifts in fluid from the intravascular space, and it will go into the interstitial space, causing edema. Remember when I said albumin was really important for a lot of body systems? It really is. So how do we manage fluid volume excess? Well, we got to treat the cause. If it's heart failure or kidney failure, we need to fix those issues. We do talk about heart failure in block 1, so you will learn more about that soon. But kidney failure, you discuss in later blocks. We use a lot of diuretics to force the kidneys to excrete the excess fluid in the body. Furosemide or Lasix is usually the first drug of choice. If the person's having really, really bad fluid excess or the kidneys are not working, we can use dialysis, which is like an artificial kidney machine, to remove the fluid. You're going to learn more about that in later blocks. Nutrition-wise, we will restrict their dietary sodium to 2 grams or less per day. We may restrict the amount of fluids they can drink per day. And don't forget that ice chips count as fluid. And if their albumin is low, we may encourage protein intake. However, that's not a quick fix. So sometimes we actually give IV albumin to quickly raise the albumin levels and force some of the fluid back into the intravascular spaces. If the provider orders IV albumin, we normally follow it with IV furosemide to make the kidneys excrete that extra fluid we just forced back into the intravascular space. As nurses, we monitor strict eyes and nose, daily weights, and assess the heart, lungs, edema, and skin. Edematous skin is at high risk for any kind of skin breakdown. We're going to monitor responses to the medications we give, and we're going to promote adherence to the dietary restrictions. We monitor and avoid any excess sodium intake from their foods and from any medications like IV solutions. We also promote rest because all of that extra fluid in the body makes the heart and the lungs work harder, and the person can get weak and they can fall easily. To help with breathing, we can elevate the head of the bed to 45 degrees, but we also need to watch their sacral skin to ensure that when they're sitting up, they don't get any breakdown in their sacrum. We can elevate the arms and legs on pillows to help any edema return back to circulation. And we can use TED hose and SCDs to help force the edema back into circulation. If the person has really bad scrotal edema, we can use a towel to elevate the scrotum or even use a jock strap to provide compression to push the scrotal edema back into circulation. Regardless of what the fluid volume deficit issue or the fluid volume excess issue, the outcomes of either problem are the same. We want the patient to maintain adequate fluid intake and output balance. We want the urine-specific gravity to go back to normal, and we want the lab values to go back to normal. We want the person to know and practice self-care behaviors that will prevent these fluid imbalances from happening again in the future, especially if the person has other diseases like heart failure or kidney failure. People with fluid imbalances due to heart or kidney failure unfortunately come back with these issues repeatedly. We also want the person to be knowledgeable and to be able to identify and report signs and symptoms of their fluid issues to us or to their provider. And this is the end of fluid and electrolyte imbalances.